Thank you so much for inviting me to join you today. I'm going to, with Katrina's permission at some point in here, repeat a couple of her slides because I think the reinforcement is going to be important. So if you see something that looks really familiar, you're not mistaken. So let's just talk briefly about what our objectives are today. I want to make sure that people have some awareness of what our current statutes are that address opioid misuse. I want people to be aware of strategies that other states are using, what's on the table for this year in the Oregon legislature and potentially going forward, which again, Dr. Hedberg alluded to earlier, and then talk a little bit about how you can engage in advocacy in this arena as well. So these are some of the repeats. Just a reminder, we are really, really high on the list of non-medical use of prescription opioids, and that's something that we have to fix. With an enormous percentage, 5% of our population of 18 to 25-year-olds, 9% of 18 to 25-year-olds. That's 10% of our kids at some of the most developmentally important times of life are using prescription opioids in a non-medical way. Lots of hospitalizations, lots and lots of deaths, and most of those are people in the prime of life, 18 to 44. And these are those slides that you saw before. We're starting to make progress, as people have alluded to, but we're nowhere close to where we were even 10 years ago. And we've got to make really good progress to get us back in that direction. I'm just zipping through these because you just saw them, but I think the reminder is important as a framework for the other things I'm going to talk about. Again, you're going to see here that, does this have a magic little pointer thing on it? Yes? Maybe? No? Yes? Did I get there? Oh, I did. Cool. Except now I can't see it. Oh, there we go. Okay. So, you know, if you look at this number in these 2 years, these 18 to 64, which is basically most of the working life, we've got the vast majority of people who are dying from opioid overdoses are in opioid or other psychotropics in this really prime time of life, this standard adult years. And that's just, those are people whose deaths devastate families, who leave people economically bereft, and really cause enormous pain and suffering to our entire community. So this is not just a public health crisis, but it's a human potential crisis. And we know that for every one of those people who dies, there are literally hundreds of people whose lives are significantly impaired by these drugs. And again, as was alluded to by the question, we're seeing a decrease in the prescriptions. It's not a lot, but it's real. And if you consider that Oregon has about 4 million residents, then that total number drops a lot, and that's great. And again, as Dr. Hedberg mentioned, we are definitely seeing a decrease in the MEDs and not just the number of prescriptions. So that's really important as well. This is a slide that I want to show that I added something to. You'll notice little symbols, an asterisk, a little plus sign, and the pound sign here. And it's because as we go through, I want you to point out that I'm using that as a way to talk about which strategies help in which of these areas. So the little asterisks are ones that help in the area of limiting prescription opioids, offering alternative therapies. The little plus signs are the ones that talk about promoting access with naloxone rescue, treatment of opioid misuse disorders, and then the pound sign are data, which help us lead to evidence-based interventions. So as we go along, this little footer will be on the slides, and you'll see those little symbols next to some of the strategies, and I think that's important to help us think about how do we categorize it and potentially implement the ones that address as many of these areas as possible. So what do we have currently? Well, we know about our prescription drug monitoring program. Every prescribing provider in Oregon, regardless of the initials after your name, has access to this and can get a sign-in to this. We also now have the ability from a couple of years ago, legislation we passed a couple of years ago, to designate people in our practice. So our medical assistants, nurses can be designees and can go ahead and look up patients of opioid use in the database, prior to their visit as part of the morning scrub, the prep that we do every day for our practices. And that's just like checking immunization status, right, for kids. It's just as important, and we need to be aware of that. The interface for the PDMP itself has improved substantially. I'll take some small amount of credit for that because I got very grumpy with the health authority and worked with them to improve it, because I found it so incredibly clunky that no wonder people weren't using it. It's better. It's not perfect, but it's definitely better than it was 2 years ago. And we do have, as Dr. Hedberg mentioned, House Bill 4124 that we passed just this past year, which will improve integration of the PDMP into our really well-designed and national model emergency department information exchange program. So for those of you who work in emergency departments, you know that ED offers you the opportunity to basically look up a patient and see all of his or her emergency department visits over the past year, I think. And that gives you some sense of whether people are basically ED shopping or have gotten other tests or other prescriptions in other emergency departments across the state. So that's really an exciting thing. We also have a pilot project going on now down in Jackson County, Medford area, where they're working hard to identify people at risk of overdose, and they've got a system in place that they're using to educate prescribing providers. They've got sort of a scale of people, and they're working with pharmacists as well. So we're trying some different things to see what's happening. And helping people identify, have tools available to identify people who are most at risk of opioid misuse. We've also done a lot to increase naloxone availability. In Oregon, pharmacists, physicians, nurse practitioners, and PAs all are allowed to prescribe to individuals directly. So any person can walk into a pharmacist and say, I have a family member I know is misusing opioids, whether that's prescription or heroin, or misusing benzodiazepines, and I need to, well, the naloxone won't help with benzodiazepines, but anyway, I need to have this naloxone available because if they overdose in my home, I want to make sure that I have what I need to treat them and temporize until we get EMS there. That's been a really successful implementation. We're starting to see an increase in those prescriptions. I'm really intrigued by this idea that Dr. Hedberg mentioned that I hadn't heard before about this pilot project in the military to offer naloxone at the same time as you offer an opioid prescription, because it shows people how serious you are about the addictive potential and the danger potential of these drugs. So that's an interesting opportunity for us to consider. There's also increased training for naloxone use through the OHA program. The URL for it is right up there. That site, by the way, in general, that Provider Partner Resources, is a really, really good site for all sorts of things that the OHA has to offer. I started exploring it the other day when I was getting ready for this talk, and I thought, wow, there's a lot out there for practicing providers, so go for it. We also have in the state Good Samaritan coverage, so if you give naloxone to somebody who's overdosing and they have an adverse effect and you're doing it just as a passing Good Samaritan, you do not have liability, even if you yourself are a medical provider. So if it's someone you don't have a provider-patient relationship with and you give it, and you, in a legitimate attempt to save their life, you are not liable for any adverse effects from that medication. And that's an important thing to remember because it empowers people to get the naloxone, to keep it, and to learn how to use it when they need to. And I think those are all really helpful policies. And you can see some more of these things here. We talked a little bit about the Oregon Opioid Prescribing Guidelines Task Force, which really addresses all three of these areas pretty well, these intervention areas, and the website for that is up there. We also passed legislation in this state that we do not prosecute people who are also using drugs if they are found to be using drugs because they reported an overdose. Give you an example of this. When my older daughter was a teenager, she was at a party where somebody developed alcohol poisoning, and they called the police and EMS, which they should have done. And all the kids who were there, who had also been drinking, my daughter included, were not given minor in possession. And that's really important because the police were happy that they'd saved this other person's life, because he would have died if they hadn't reported it. So we don't want users of alcohol or other drugs to not do the right thing because they're afraid of getting prosecuted for misuse of these drugs. So we've passed legislation to protect people in those contexts as well. You also cannot be prosecuted for opioid misuse if the way your opioid misuse is discovered is because you yourself present for treatment. So, if you end up in the emergency department with an overdose, they're not going to arrest you for using opioids or being in possession. So that's really important as well. We also, with Medicaid, have the ability for the health authority to restrict Oregon Health Plan members, beneficiaries, to getting their opioid prescriptions at certain pharmacies. So, for example, OHP can say, well, you've been getting your opioid prescription at this pharmacy. We're not going to let you get it filled at any other pharmacy, which can decrease overprescribing in that way, which is important because over a quarter of Oregon's residents are on OHP. So that helps address it in about a quarter of our population. Mind you, they are no more at risk for opioid misuse than the rest of our population, except maybe our Medicare population, which is another quarter of our population. But the other 50%, just as much at risk. So this is not just an issue for our lower income population. We know that in Oregon, we have mandatory pain management education. All of you who are sitting here meet it, but you also had to meet it either the way I did back in the late 90s, early 2000s, when we had to sit through 6 hours of kind of boring pain management education. And if you want to get licensed in this state, you have to do it within 12 months of getting your license. It's important in general, but it's got to be useful and it's got to be up to date. So there's no ongoing requirement, which overall, as a physician, I think is a good idea because I don't think the state should be mandating continuing medical education. On the other hand, I do think that we ought to be working hard to make sure people stay up to date on the most current guidelines. As Dr. Hedberg mentioned, Medicaid and many other insurers are now paying a lot more for alternative modalities, right? You used to only have the option for people with pain on Medicaid or certain other insurers to prescribe opioids. You couldn't prescribe physical therapy. You couldn't prescribe psychotherapy. You couldn't prescribe massage. You couldn't prescribe acupuncture. You couldn't prescribe chiropractic, all of which have been demonstrated in certain situations to be evidence-based interventions for certain kinds of chronic pain or even acute pain. And we need to have those modalities at our fingertips, but when we were limited by insurance coverage to oh boy, I'm not doing so well with the words this morning. It's been a long week. First full week of session, and I don't think I've stopped since last Sunday afternoon. So bear with me. So when our only option was opioids, then we really didn't have an opportunity to do what we knew was evidence-based and give people more appropriate care, and now we do. On the public safety side, criminal justice side, there's been the development in more and more counties of drug courts, diversion therapy. Instead of automatically incarcerating people for possession of controlled substances, we are diverting more and more of them into treatment programs, putting them on probation until they complete those programs and stay sober for a period of time. And that has multiple positive effects. It gets them off of the drugs, we hope, and it means that they don't end up with felonies on their record that can make it tough for them to get jobs and become law-abiding citizens. So it's really a multifactorial win for us when we do that. It's less expensive than incarcerating people, and in the long term, again, we're talking about maximizing human potential, and that's really important. So those are starting to work really well, but not every county has them, and some counties that do use them more than other counties. And so we need to increase the use of drug courts in this state. So what are our problems? First and foremost, the use of the Prescription Drug Monitoring Program database is not universal among all of the prescribing providers in Oregon, nor is it consistent among those of us who do use it. Many practitioners, I'm going to show you data in just a minute, have not even registered to use it. Or if they're registered, they haven't designated a surrogate who can help them. So they haven't designated an MA or a nurse in their practice who can look this stuff up for them. The awareness of the naloxone prescribing is not widespread. We have not done as good a job as we should of publicizing that. We need to be thinking more about how do we get that information out to friends and family members of people who are known opioid users and make sure that they have access to this life-saving treatment. Again, naloxone is a temporizing measure. but it's a life-saving temporizing measure. And it's the kind of thing that can eventually push somebody into treatment because as any opioid user who's ever been given naloxone will tell you, it's sort of a rude awakening because you are literally yanked back from the brink of death and all of the opioid effect goes out of your system for a period of time. It's sort of like being taken from a hot shower and dunked into a ice-covered river, only worse. So not so good. But we do need to educate people about it and make sure that more people who know people who are opioid users or even opioid users themselves get the naloxone, have a friend or family member who knows how to use it and is aware of it. The other thing, I don't know about the rest of you in this world, but with my doctor hat on, I will say that I felt a little whipsawed sometimes about what's expected of me for pain management. I see a lot of heads nodding. There was a time when we were told that, I mean, I've been a physician for 25, almost 30 years now, and I will tell you there were times when we were told not to give opioids to anybody, practically, because we were creating addicts right, left, and backwards. There were times when we were told we were under-treating pain and it was terrible, and we were cruel and heartless people, and we need to prescribe more of them because pain is a vital sign, which it is, but again, how do you manage that? And then we were told, oh, no, you're prescribing too many opioids, and we got to fix that. So it's a little tough, right, as a prescribing provider to understand. So we have to figure out ways to communicate clearly. This is, to be honest, not atypical of any other medical condition, right? It's very tough to disseminate new information to us. We're all very, very busy in our practices. It's tough to pay attention to all the new evidence coming across our desk that's relevant. And it's very hard when you're told one thing 1 year and 3 years later you're told something else, and then it's back to the first thing or somewhere in between 3 years after that. So we have to do a better job of communicating with prescribing providers. So let me show you some data on this, which I think is really important. You'll see here, there we go. This is the list of the disciplines. These are nurse practitioners, dentists, DOs, MDs, naturopathic doctors, PAs, and optometrists, who, for reasons somewhat unclear to me, also have narcotic prescribing privileges. And here's who prescribes them, right? Nurse practitioners, 2,100 of them since 2014 have prescribed at least once. Dentists, 2,500 of them. DOs, 800. Physicians, almost 9,000. MDs, about 9,000. Naturopathic physicians, almost 400. PAs, 1,200. Optometrists, 70. But now look at this. The percentage of these people with PDMP accounts, the highest is 66 for the nurse practitioners, 65 for the DOs. SMDs, 44%. Not so good, guys. And the naturopathic physicians are higher than us, too, at 51%. So these numbers, really not good. There's not a single one anywhere close to 100% with prescribing privileges with PDMP accounts. And you know that if they don't have a PDMP account, that they don't have a designee who has a PDMP account, because you have to have one first before you can designate. So if you have a tool and you don't use it, a really important, really useful tool, and you don't use it, that's a problem. We got to figure out how to solve that problem. The other issue here that I want to point out is that we don't have sufficient treatment programs in this state. I think everybody knows that it's tough sometimes to find a treatment program for somebody who's interested in going into treatment. It depends a lot on what kind of insurance they have, and there are very interesting problems with restrictions. I'm doing a lot of work in criminal justice right now in public safety and trying to reduce some of our public safety costs. And there was some work being done in Multnomah County about people who end up in what's called community court. Those are sort of nuisance violations, right? And they discovered that there was one man who had ended up in community court 100 times in the preceding year for public intoxication or public urination or little things related basically to the fact that he was an alcoholic. He wanted treatment. He had one sex offense conviction 30 years ago, and he couldn't get into a single alcohol treatment program because of that. The guy wanted treatment. right? Now that's alcohol, it's not opioids, but it's the same problem, right? And it's in evidence. So when you have a shortage of treatment beds and a shortage of available payers, then the programs get to be choosy about who they take in. Frankly, it would be cheaper for the system to develop a program just for that one guy alone. But the point is, we've got to figure out ways to expand them. We also don't have great understanding. I was telling Dr. Hedberg, and she alluded to this a little bit in her talk, that there's a lot of misunderstanding about concomitant use of cannabinoids with opiates. I got an email from one of my colleagues, another senator, who got an email from one of her constituents saying that they were trying to cut down their doses of prescription opioids, and they were using marijuana to do that, and they found it more effective and less impairing than opioids, and yet their physician refused to prescribe opioids because they were using cannabinoids at the same time. I get it, it's scary. Marijuana is also a depressant at some level, but you got somebody who's trying to do the right thing. It's a legal drug in this state. You wouldn't tell someone that you wouldn't prescribe opioids if they were using alcohol. It wouldn't be a good idea for them to use them at the same time, but you wouldn't not prescribe. So we've got to have some balance. We've got to have some continuing education of providers in this state so that we're sure that people are clear that you have to have some judgment about this. You could choose with certain people to say, okay, that's not going to work for you if you're using this much marijuana and that much opioids, but there's got to be a middle ground. The last thing that I really want to point out is data. And I have said over and over again that the two words that I will be using the most this sentence, well, there's probably more, budget's high on the list, but are data and evidence. And we need to be doing a much better job of collecting evidence about prescribing patterns, about who's at risk for opioid misuse, about the efficacy of different treatment programs, right? We do not have great data about which treatment programs work the best. We don't have great data about who's really using these drugs. We have some sense, but because there remains a significant stigma around opioid misuse, just as there is around misuse of any other substance, we are not able to really get at the true depth of this problem. So one of our challenges as a state is to destigmatize opioid misuse, make it clear that this is not a moral failing, but rather that these are very addictive drugs, and we need to get an awareness of how many people are using them so we have a sense of figuring out how do we intervene earlier, what are effective early intervention programs, how do we prevent the problem in the first place. And people are worried about risk of prosecution, which again, we've been trying to get there. And in fact, one of the exciting things for me this session, which I guess I'll get to in a second, is that the sheriffs and the police chiefs are recommending decriminalizing possession of small amounts of any controlled substance. So that's a really exciting opportunity for us. Our political reality in Oregon. We have the challenges that we've addressed a little bit in the context of cannabis legalization. People don't really know how to think about that drug anymore, and they don't know how to think about it in the context of opioids, and how do you think about what's an appropriate use of cannabis in the context of opioid or benzodiazepine use, prescription or non-prescription opioids. We have to get tough on the addiction without demonizing the addict. Right? Because again, we know as healthcare providers that addiction is a disease just like diabetes or high blood pressure, and it is not a moral failing, but rather it is something that we have a societal obligation and a healthcare professional obligation to figure out how to treat effectively and intervene. And it's exacerbated by the fact that non-prescription, non-medical use of opioids or use of non-prescription opioids, heroin, are illegal. And that's tough because all of a sudden they're criminals as opposed to just people suffering from a medical condition like addiction. So that's a challenge, right? Diabetes is not illegal. Maybe unwise to do certain things if you're a diabetic, but it's not illegal to do them. And we have that challenge, which is one of the reasons I'm excited about this initiative from the police chiefs and sheriffs. We have to balance information sharing with privacy concerns, right? On the one hand, we have historically treated information about mental health and substance abuse in a different way than we've treated other medical information because of the stigma associated with it. On the other hand, treating that information differently exacerbates the stigma, right? If you treat it differently, it must be because there's something wrong with it, or there's something bad about it, or the person who has that information about them, there must be something shameful about that. And we need to be very, very public about the fact that this is a pervasive problem and that it is no different from any other medical condition. We're making good progress with doing that with depression and schizophrenia and bipolar disorder, all those kinds of things, but we haven't done as good a job with addiction, which again is a biochemical disorder that we know needs to be treated. Yes, there are psychological underpinnings. Yes, you need other kinds of behavioral therapy to help you cope with it, but that's true for lifestyle modification for diabetes too, right? We need other kinds of interventions. We'd have to do something that I've been alluding to all along, balance criminal justice issues with public health issues. And we have, I told you, my favorite word this year probably is budget. We don't have a lot of money. And that's true certainly in the state budget. The budget committee that I co-chair between the Oregon Health Authority and the Department of Human Services, we're looking at a $1.4 billion with a B deficit, shortfall, depending on how you look at it, despite Oregon's economy growing and having an additional $1.3 billion in revenues. So we're in a tough place on that, and we have to figure out how do we use those dollars as wisely as possible. And speaking as somebody who's been living in this world for a long time, and frankly, I think if any of you in this room isn't aware of this at this point, you've been living in a blissful bubble. Almost anything can be politicized, right? And so you have to be really careful how you approach these issues from the political perspective and the public policy perspective to make sure you're framing them in ways that are politically acceptable. So what are our options? Well, some states require practitioners to review their equivalent of the PDMP before prescribing. That gets at reducing prescribing. That gets at giving us data on what prescribing patterns are and using data to reinforce appropriate prescribing patterns. I don't know if that's the right option for Oregon, but I can tell you I'm going to be really intrigued by that idea if we don't see the percentage of people using it going up really, really fast. Really fast. And so we have to be thinking about that as an option in Oregon. We can make abuse-deterrent opioid formulations exempt from substitution requirements because there are abuse-deterrent formulations of some opioids, prescription opioids now, but historically they've been substituted for because they're more expensive. So we have to think about whether that's an option because it means that it's harder to misuse prescription opioids. We can, as Dr. Hedberg alluded to, improve oversight of pain management clinics. In some states, they are actually regulated separately, just the way ambulatory surgical centers or hospitals are regulated by the state. Again, we'd have to think about how do you define a pain clinic, but there are definitions of that out there, and we certainly need to be looking at some of these pill mills that Dr. Hedberg alluded to. You can add reporting requirements for treatment programs, and that, frankly, strikes me as a really important option that we need to consider. We can talk about program completion rates, we can talk about relapse rates at 1 and 5 years, and we can talk about breaking those demographics, those relapse rates down by demographics, because we know that different demographic groups respond to treatments in different ways. And we need to know which kinds of treatment and which kinds of intervention are most effective for different demographic groups. We know that we have to prescribe different drugs for hypertension, sometimes depending on demographics or other underlying conditions. And there's no difference in that and addiction treatment. Some other options. To decrease the disease burden side of opioid misuse, needle exchange programs. Utah has a pretty robust program. Indiana actually now has one because of their big HIV epidemic that they had in southern Indiana. And that decreases disease spread among IV drug users, and it also gives an opportunity to expose people to education about treatment options. When they exchange needles, you can give them information about treatment options. One of the most interesting new ideas that we're seeing in terms of preventing the deaths associated with opioid misuse is what's called safe use sites. Some of you may have heard some of the stories about this recently. Seattle is the first place in the country that's proposing this. Basically what they are, and they've been used in Europe for a while, is a site where people can come use opioids in a supervised environment without risk of prosecution, and there are people there who are trained that if they see signs of overdose that may lead to significant adverse effects, to intervene. I'm not 100% sure how I feel about that one, but I think it's an intriguing idea, and I think it does go a long ways towards decriminalizing and destigmatizing it, and I think that's an important part of the conversation. I don't know how many people would choose to use them, and it's an early story in the United States, but I think we have to put all the ideas on the table. Public education is really important. We've done a pretty good job in our public education of starting to educate middle school and high school kids about tobacco, some about alcohol, but we haven't really talked about prescription opioids. And people don't understand that prescription opioids are just as addictive as heroin. And we don't tell them to be careful when their doctor prescribes, when their dentist prescribes opioids when they have their wisdom teeth out, right? And that's a place where people get addicted. So we need to be thinking about those kinds of education programs and including prescription drugs in them, and increasing our public education campaigns about prescription opioid misuse as well. Let's see here. There we go. Okay. One of the things we can do that many states have done, and we have this coming on the books this year, is to limit the amount per prescription, especially the first time something's prescribed. Usually the amount is for 7 days with no refills, and you can't do refills on controlled substances in Oregon anyway, but usually it's for 7 days. One of the caveats for that 7-day number is that even may be too much. Many conditions, simple fractures or tooth extractions, don't need opioids for more than a day or two to manage the pain, and yet they get prescribed a lot. The Oregon Dental Guidelines from the Oregon Dental Association and the Board of Dentistry say that they should prescribe no more than 3 days worth or 10 pills. And yet, I can tell you that for both of my daughters, when they got their wisdom teeth out, they got 30 Vicodin just prescribed routinely. I didn't bother to fill them. I'm a mean mom. No. No, actually, they didn't really need them. But you got to balance pain management, right? You don't want people miserable. We know that insufficient pain management leads to poor recovery and poor healing. So you do have to consistently work on balancing all of these issues. You can require patient education about addiction risk when dispensing opiates or benzodiazepines. That's often done at the level of the pharmacy. You can have standardized handouts that are given that the pharmacist is required. People can't just sign, oh yeah, I've taken this drug before. They have to specifically have counseling with the pharmacist about the risk of addiction with these drugs. That strikes me as a pretty intriguing option as well to add in. Drug take-back programs are really important. What do you do with those leftover opioids when your kid's prescribed 30 Vicodin for their wisdom teeth and they take 3 of them? We really don't want them sitting around in people's medicine cabinets where people can use them for inappropriate things, or sell them, the kids can sell them to friends or whatever. So drug take-back programs, whether they're at the pharmacies themselves or through postage-paid mailers that go back, or a range of other options, are very important for all of us. And frankly, they're important for getting all prescription drugs out of our environmental system. We know that if you test water in most of the major systems in this state, you will find traces of statins and antidepressants of one sort or another, and you can find them in our fish. So frankly, when you eat local salmon, you may well be getting microdoses of fluoxetine, which probably wasn't what you intended. Omega-3s, yes, fluoxetine, no. So we need to be thinking about ways to get all prescription drugs out of people's medicine cabinets when they're no longer being used or they're expired. So what's next for Oregon? We need to limit the amounts prescribed. We've got one of those 7-day proposals coming. We've got drug take-back programs, both in a mail-back version and a pharmacy accept-them version. We can decriminalize possession of small amounts of controlled substances, which, as I've told you, is a major proposal by our police chiefs and sheriffs. One that I personally am strongly supportive of, and I would encourage you to be as well, because it's a waste of everybody's time, money, and energy, and it clogs our courts, and it means that people are getting criminal convictions instead of the necessary treatment. So we need to be thinking about how to be using our resources more wisely. We need to be encouraging all insurers to cover a range of alternative therapies for pain management. And again, those are conversations that we're having at the legislative level. And we need to increase use of the prescription drug monitoring program. The stats that I showed you earlier were from the end of 2014. There was a mid-2016 goal to target the 95% of the 4,000 practitioners who write 78% of the prescriptions, which is a complicated number. But if you go back, let me just see here, 1 second. Let me go back to this one slide for a minute. If you go back to this slide, you'll look at the almost 16,000 people who prescribed at least once. As it turns out, only about 4,000 of them write 78% of the prescriptions. 2,000 of them write 55% of the prescriptions, right? 2,000 out of that 16,000, 1/8, 12% write over 50% of the prescriptions. Now, some of that's not surprising, right? Certain kinds of physicians or dentists are going to be prescribing a lot more of these because of the nature of their practices, and we get that. But we have to be sure that those are being prescribed appropriately, and we have to be sure that the people who are prescribing the most are using the PDMP appropriately. So let me just go back to that last slide here. Yes, I have a minor in PowerPoint. The joys of being in academic medicine and public service. So, you know, we need to increase that. There was a target. I haven't seen the latest number. Maybe, Katrina, have you seen whether we're at that number yet? No, we don't know. We're hoping to be there. But we need to increase the use, and we need to increase the use of designates. Do we think we're at the point where we should be mandating use? I don't know. I need to see what the numbers look like now and how often these are being used before prescribing. But I'm getting pretty tempted to require it because I think that people have a tool at their fingertips, just like whether it's measuring someone's blood pressure to decide whether you need to prescribe more medication or checking an A1C to see whether the diabetes is under control. Why would you not use the PDMP to make sure that it's that you're prescribing the right drug in the right quantities? So that's something we need to give serious consideration. We need to have it more integrated into all the different kinds of electronic health records, so you don't have to go into an entirely separate system. But the work that we're doing now to integrate it into ED is a really important step in that direction, because basically building bridges. And I'm actually done, so we're all good.